Good afternoon, everybody. Thank you so much for joining us. Looks like a wonderful group of people joining us today. My name is Dr. Heather Flynn. I'm a professor here in the Department of Behavioral Sciences and Social Medicine at the FSU College of Medicine. And we are just delighted to bring you the second in a series of our Behavioral Sciences and Social Medicine community rounds. And today we are focused on rural healthcare access in Florida, serving the underserved. We love to pair faculty members with community members to come around these important topics to discuss. And we have a wonderful panel today that I will introduce in a moment. Before we get started, I wondered if we have Dean Fogarty, Dean of the FSU College of Medicine, with us today. I wanted to give you the opportunity to say a quick welcome, Dean Fogarty, if you'd like to.
Well, thank you, Heather, and thank you for organizing this second Behavioral Science and Social Medicine Grand Rounds. I really appreciate that in spite of all the things we're doing with COVID and everything else, that we can still get together, put together incredible programs. And you're clearly today talking about things that are right in our mission foci. So we're excited to hear this. I wish we were together in person, but obviously the turnouts for these has been really good. So I guess Zoom will have to still work for us for a while, but thank you to everyone who's here, and let's get on with the show.
Thank you so much, Dean Fogarty. And we are thinking about, well, we're hoping for the spring to maybe move to some kind of hybrid format, because we would love to see people in person as well. So as I said, we have a wonderful group of panelists today. I'm going to introduce the panelists and then turn it over to Dr. Bryant Howren to make a few comments before we get started about our important topic, which, as Dean Fogarty mentioned, focusing on rural health is a very important mission of the College of Medicine, and I know for a lot of you in the community. So we're very fortunate today to have with us, first of all, Dr. Kerwin Flowers. Dr. Flowers is an assistant professor in our Department of Family Medicine and Rural Health here at the FSU College of Medicine. She currently serves as the Director of Rural Medical Education and the Director of Year 1 Clinical Skills, which we're all very thankful, and she's doing a wonderful job, and I'm so happy you're in that role. In her clinical role, Dr. Flowers practices general family medicine and teaches in the context of direct patient care at FSU Primary Health. She also serves as the faculty advisor for the Florida Rural Health Association. Next up, we'll have Miss Elizabeth Pate. She is a program specialist with the Swanee River Area Health Education Center and co-manager of the Florida Rural Health Association. Elizabeth has been trained as an Echo Hub partner and provides groups of community providers with the ability to connect in real-time collaborative sessions around pressing topics that directly impact rural Floridians. If you're familiar with the Echo model, it's a fantastic dissemination model. Elizabeth has over 15 years experience in nursing and association management and recently completed her MBA at Nova Southeastern. And I've had the pleasure of working with Beth on a few things, and really excited to have you here. Next, we'll have Miss Kalyn Lewis, who is the HIV Program Director at Well Florida Council in Gainesville. She manages the Ryan White Part B program and the Housing Opportunities for Persons with AIDS program for a 15 county service area. She earned her Master's of Public Health from University of Florida and has worked with Ryan White clients since 2013. Last, but certainly not least, we'll hear from Dr. Bryant Howren. Dr. Howren is an associate professor here in the Department of Behavioral Sciences and Social Medicine at the FSU College of Medicine and is the director of the Florida Blue Center for Rural Health Research and Policy. Prior to joining FSU, he was co-director of the VA Office of Rural Health Resource Center in Iowa City for over 7 years. And much of his recent work focuses on increasing access for rural veterans receiving community-based care, particularly for mental and behavioral health needs. So I'm really excited to have this panel here. I will quickly acknowledge our BSSM Community Rounds Committee, Dr. Meredith Pooler-Burgess, Dr. Seyram Budame, Dr. Bryant Howren, and myself, and with the help of Uta Horn, we have loved working on this series, and I thank everybody for their work. So without further delay, I will turn it over to you, Dr. Hauer, for a couple comments and then get right into Dr. Flowers.
Great, thank you. Good afternoon, everybody. I too want to welcome everyone to the latest session here for our Behavioral Sciences and Social Medicine Community Grand Rounds. This one on rural healthcare access in Florida. As Dr. Flynn had mentioned to several of us earlier in the week, this is number 2, so this is now a thing. And I think we're all glad that it's now a thing. And hopefully you'll be able to take something valuable away from it. We planned this session actually in part because of its proximity to National Rural Health Day, which is tomorrow. Many individuals in our surrounding communities and at FSU live and work in rural areas or have family members who do. And some of us were raised in rural areas, and that's me included. So if so, you likely know the many challenges that rural residing individuals face in order to obtain timely, high quality, and culturally sensitive healthcare. Many rural areas are health professional shortage areas, making access to such care even more difficult. And perhaps even impossible at times without creative solutions that can rarely be boiled down to simply broadband telehealth. Our speakers today will touch on some of those issues and highlight a number of what I think are very creative ways in which they assist rural Floridians, with improving access to care. So with that, I will turn it over to our first speaker, Dr. Kalyn Flowers.
All right, well, good afternoon, everyone. So again, Dr. Hauer has already touched on a few of those things that I will definitely discuss with you today. Gonna make sure that we can see my PowerPoint. Again, I'm a family medicine doc by training, and I wanna lead with that. I just happen to be a family medicine doc that happens to teach and not the other way around. So I wanna lead with that I practice on a weekly basis, and I see patients in the office, and I wanna come from that standpoint. But I'll put on my Director of Rural Medical Education hat just a little bit as we move forward as well today. So I want to just start off by making sure that we're all on the same page. So if it's okay with you, just start with a few definitions. And again, Dr. Hauer has already touched a little bit on some of this, but just making sure that we're all on the same page. So what does it mean to have access to healthcare? Well, it is this concept of having timely personal health services to achieve best health outcomes. And it really has 4 major components: coverage, services, timeliness, and workforce. And so just to think, someone who may be uninsured, they will be less likely to receive medical care for several reasons, but let's point out a couple of those reasons, and that being that they don't want to rack up bills, right? So they don't want to have a whole lot of bills coming to them that they cannot pay for, so they may not seek health care. And on the other side of that is there are a lot of organizations that don't accept patients who don't have health insurance. So there's kind of this dual nature of why people may not have coverage or may not have this access to healthcare, which kind of comes into the timeliness as well, that some folks may wait until it's the last resort or the last minute to seek healthcare because they didn't have access when they needed it earlier. So again, having this ability to provide the healthcare when the healthcare is needed. So it kind of relates to the timeliness issue as well. So services. So it means access means having the usual services, especially those that relate to screening and prevention services, things like mammograms and pap smears and colonoscopies, regular child visits or well child visits or yearly visits for adults. So those types of visits. And then the workforce component is really important as well, because to have good access, you have to have a good, capable workforce, people that are there to see those patients as well, competent providers. And we'll discuss that just a little bit as we move forward into our presentation today. So another definition that we want to make sure that we are on the same page about is this, this business of being underserved. And so it's a literal definition, as you can see, that implies decrease in healthcare services or access to healthcare, which we just discussed. Understanding that the underserved face barriers to accessing and using these services, and we'll speak about that in our presentation today. But some of those barriers include their geographical locations, religion, sexual orientation, gender identity, different racial and ethnic populations, as well as special needs populations, patients who have disabilities, or their citizenship is kind of controversial, as well as patients with language barriers. And we'll touch a little bit on all of those in this brief presentation. So why? Why is it important to me? Why is it important to FSU College of Medicine? It's important because our university was really founded, our College of Medicine was founded on these principles. Firstly, to educate and develop these exemplary physicians that we're hoping to release to the world one day. And also to really be responsive to community needs, especially those of elder, rural, minority, and underserved populations. So institutional wise versus personal wise, it's very important to us. It's our why. For me personally, as Dr. Howard mentioned, I'm from a rural background. I'm actually from Quincy, Florida, so Gaston County. And so raised in a rural environment, and I've had the opportunity to be on both sides of the tracks, if you know what I mean. So I've seen both sides of the coin as a patient, as well as a healthcare provider. So very personal to me, and that's my why for being involved today. So access to rural primary care, or decreased access to rural primary care, is what we're going to speak on, is what the majority of our presentation is about today, or my presentation is about today. And so in any healthcare system, to deliver optimal healthcare, regardless of where you are, whether that's in a rural area or in an inner city or suburbia, there are some things that are just absolutely necessary. So it's technologically demanding to do so. It's very costly. And again, that workforce is coming up again, that we need a good quality, qualified workforce in those areas to provide good quality care. And these features can be really difficult to have in any healthcare system, no matter where you are. But it is even more difficult in rural areas due to those limitations that we talked about, but also limitations that may be specific to rural areas. And I want to get into those in just our next slide here. So here's some of the barriers. I want to emphasize that these barriers are not all inclusive, but just a few of those barriers that we'll speak on very briefly today. And as we go through them, I want you to be thinking about things from a systems level versus a community level versus a personal or individual level. So some of these things can be problems on all of these levels, but sometimes they may fit in one of these categories more than another. Some of the things we'll discuss briefly today are resource limitations, confidentiality limitations, patient-provider travel, service access, and training constraints. Let's quickly go to resource limitations. And for this one, it is just thinking about the number of providers as it relates to how many providers we have in a particular area versus the amount of people that are in that community. And in rural areas, there's really generally way more people than there are providers. So we don't have enough providers to go around. So there's this resource limitation in providers themselves. And then when there are providers, sometimes there's this limited expertise in certain problems and illnesses. And so again, think about, some of the rural areas have limited access to OB health or OB care, mental illness care, chronic pain, and substance abuse. So again, I'm a family doc, so I'm trained pretty broadly, but I may not have the expertise I need in certain areas to be able to handle a rural population, especially if I came from a training area where I had a specialist for sort of everything. And that changes in the rural environment where sometimes it's only you. So you're the OB, you're the mental health person, you're the chronic pain person, you're the substance abuse person. All of those things fall on your shoulders, and we'll talk about that as we move forward. So limited access to consultants, we just kind of mentioned that. So who do you send to rheumatology when the nearest rheumatologist is 3 hours away or 2 hours away? And so patients may have these limited resources to specialty areas as well as community resources. And I mentioned things like food banks and bus routes, and you might be asking, well, why does this matter? How does that have anything to do with health? And so again, I just want to, I can't spend a lot of time on it today, but just to bring to your attention this social determinants of health and this concept of social determinants of health, where, in conditions where people are born, they live, they work, they grow, they thrive, they age. And all of these things are important to make us healthy. Good food, having a good education, good income, our environment, a safe environment, a clean water, all those things are important for us to be healthy. So good community resources, and then financial resources. So just to be thinking about some of those things as we move forward today through our speakers. So service access. So sometimes patients in rural areas have to travel great distances. And even for elderly folks, 45 minutes or an hour can be a great distance for them. So again, just thinking about how this can limit access if a patient has to drive pretty far to get to the specialist or even the primary care doctor. And the lack of access to transportation. So again, in big cities, you may have bus routes and taxis and other things that may be able to help your patients get back and forth. But in rural areas, these things are limited and literally sometimes non-existent. And then downright the patient's inability to really pay for or afford their treatment. So they're making decisions today whether to buy medication or to buy food. And so they may have limited access to finances, and this may be a problem as well. So confidentiality limitations. And I think this is a big one that's not talked about very much so, but I did have the privilege of practicing in my home town for about a year. And it was one of the most rewarding things I have ever done prior to coming to FSU and FSU Primary Health, which is where I practice now. But during that time frame, one of the things I was very afraid of is being accepted in the community. And for people to trust me with their personal information, and we do consider it a privilege as primary care doctors to be able to interact with our patients on that level. But it can be a real concern for patients that the physician or the other staff members might breach their confidentiality. Think about a lot of times in rural areas, everybody knows everybody. You're related to half the folks that you might be taking care of or somehow interacting with them at church or other social events. And so people may be afraid that you might leak their information. So it may cause confidentiality limitations for that clinician in that area. So one of the other things I wanted to mention too is this legal or ethical requirement to report certain information. And let me just give you an example of that. As a primary care doc, I'm required by law to report if I think there is a child that might be being abused or there's elder abuse. And even if I suspect it, I may not know for sure, but I'm required to report that. So think about what kind of rift that might cause in a community where people are really close knit, but you're required to report those kinds of things. And the last thing on this list that I wanted to mention is that outsider role, which is a little bit different than confidentiality limitations, but I think it's really important that a lot of times in rural communities, there's this sense of community, if you know what I mean. And so it can be a barrier because we know each other. But when people come from outside of the community, there can be a barrier as well because we don't know you. So we're not talking to you, we're not trusting you. And sometimes it takes a while to build that rapport and build that trust. And that could be a barrier as well. Time constraints. So again, I just want to say in any practice, in any area in the United States, there will probably be time constraints. But in rural areas, it can really be significant because a lot of times, again, you have many hats. You're wearing a lot of hats. You're wearing the cardiologist hat. You're wearing the rheumatologist hat. You're wearing the podiatrist hat. So a lot of those things that you would maybe save a little time by sending them out to other specialists, you are that person. And so again, the patients a lot of times have complexity. Their presentation is very complex. So they may have high blood pressure and diabetes and high lipids. And so again, trying to deal with all those things, especially with folks that may have limited transportation, you're only going to get them today. So you try to get it all done. All those time constraints can be a problem. And you don't have enough time to see your patients. So those time constraints can really be something. Training constraints. And this is something that's super near and dear to my heart. And one of the things is that, having the access for training to increase personal skills and abilities. A lot of times folks may want to come back to rural areas like myself, who's from a rural area. And we know that the statistics really support that you have a higher chance of going back to a rural area if you're from that type of background. So again, sometimes you have to go back and get more training, because a lot of doctors are not ready for what they meet when they get to these rural environments and realize that they are the ones wearing all of those hats. And so again, this is something that's near and dear to my heart, because I think sometimes there's this false sense of safety, that because I'm from a rural area, I know what to do, I know how to practice in a rural area. And that's not necessarily the case. You have to train up for where you're going to practice and make sure that you're equipped to handle the things that you might handle when you get to that environment. So a few things that are specific to North Florida that I definitely wanted to mention. We talked about some of those barriers at the beginning, but language barriers is a big one, because we do have high migrant and Hispanic populations, especially in Gaston County and right here surrounding FSU and Tallahassee area. So that's something. So again, if you don't speak, if your doctor doesn't speak your language, nobody at the office speaks your language, that can definitely be a barrier to healthcare and healthcare access. And then patient literacy. So that could be whether the language is different and or the materials that are presented are way above the patient's level of understanding. So making sure that we sort of address those areas. And then lack of extended hours. So I want to just bring that out. A lot of times in rural areas, the workforce is more blue collar. They're more 9-to-5 folks. And so think about, if you don't work, you don't get paid a lot of those times. So it's hard to take off from work to go to the doctor and to get yourself seen about. So again, offering those extended hours may help in those areas to make sure that our patients are well taken care of, and just some things to think about in the rural area. So in conclusion, I know that was a whirlwind, but in conclusion, I just want to say in rural and urban healthcare disparities, we require reform, and that reform should be aimed at improving the provision of services or providing services to our patients, increasing that access to remote recruitment for doctors. And we are actively doing that in our own way here at FSU-COM as well. Training and career development for rural health professionals, increase comprehensive healthcare as well in those rural areas. Do we still have time for rural medicine story time, Dr. Howard, or should I let someone else go next?
I think we have time to squeeze one of those in.
All right, I'll just give you one example. I would love to speak about, a lot of times when we talk about rural health access, we talk about, the bad things and what we don't have. Well, how about let's have a nice story about what we do have, and how when communities come together, even with limited resources, wonderful things can happen. And I just want to give a really brief, quick story of, again, most of my practice has been in rural areas. And so, in a previous practice that I was in a rural area, we realized that there were a lot of patients, chronically ill patients, COPD, congestive heart failure, that were utilizing the emergency medicine services quite a lot, and no showing to our primary care office quite a lot. And because the health system owned our primary care office, we could really keep track of how many of these patients were really going to ER for regular primary care stuff and not coming to the primary care office or missing their visits. So there was a task force that got together, and we put together a couple of physicians, a community resource nurse, social work, and start trying to call those patients, get a survey of those patients to try to figure out, instead of just labeling them non-compliant, right? To find out why are they missing their appointments, and why are they utilizing these emergency medical services at such high rates. Anyway, so at the end of this, after surveying those folks, found out there were financial reasons, there were transportation reasons. Mostly, it was not that they were not concerned about their healthcare and didn't want to come in. So with the help of organizations and taking up donations from vendors in the community, and the hospital putting forth a good amount of effort as well, we organized a program where patients had vouchers to come to regular family medicine visits. We had that resource nurse that would call them from time to time periodically to check on them, to make sure they had their medications, to check on their weights if they were CHF patients. So just a nice way to help the community, a nice way that community came together to help those patients that were in need and make sure they had the access to healthcare that they deserved. And so that's my story for today, Dr. Howard. Thank you guys so much.
Thank you so much, Dr. Flowers. That was just really wonderful, digestible coverage of the most important issues. We're going to pass it on to Miss Elizabeth Pate.
Again, I'm Elizabeth Pate, and I am with Swanee River AHAC. I'm one of their lead association coordinators. And as part of that role, I am one of the co-managers of Florida Rural Health Association. I don't know if many of you know about Florida Rural Health Association, but it is a statewide organization of physicians, rural hospitals, health clinics, rural governments, nonprofits, and other educational institutes of area health education centers. One of our biggest goals and missions for Florida Rural Health is to safeguard and improve the health of rural Floridians, to be recognized unified voice leaders and experts on health and healthcare issues affecting rural Florida. As part of Florida Rural Health Association, we do have a membership base. So there is the benefits of being a member, being able to network with other rural practitioners across the state. You receive monthly newsletters with news affecting the rural communities and being able to have networking opportunities. As part of FRHA, we are very big on workforce development by offering workshops, courses. We like to customize trainings to help develop and enhance their existing skills. As part of that, FRHA has a successful workforce development program by having pretty much evidence-based valued of returning participants in our Project Echoes. I don't know if anybody's ever heard of Project Echo, but I love the format of Project Echo. So if many don't know, Project Echo is based out of the University of New Mexico. It was developed by Dr. Sanjeev Arora and is a collaborative model of medical education and care management that helps clinicians provide expert level care to their patients wherever they live. He basically started it up where he was an expert in, I believe it was like a hepatitis, and he wanted other rural practitioners to be able to educate their patients on hepatitis. So he developed this model to be able to help train other practitioners. Being able to use the ECHO model, people in communities around the world are able to access critical and life-saving knowledge while receiving mentorship and ongoing support to make difference in their communities. Project Echo uses an ongoing telemedicine. Basically, is through Zoom, and we usually have practitioners. They have EMS, firefighters, like any type of high quality specialty care joins these type of echoes. Around the world right now, Project Echo programs operate in over 34 countries, and FRH uses Project Echo as a hub and spoke telemonitoring model to move knowledge instead of people to move knowledge for the people in the rural communities of Florida. Let's go back. So currently right now, FRHA offers 3 different types of echo sessions. We have a rural EMS echo where we have offered over 25 community paramedicine-based topics, such as social determinants of health needs, COVID-19, considerations for MIH teams, and program design. This echo was launched in March of 2020. It was originally supposed to be a 6-session clinic geared towards the Florida rural EMS agencies, but has now built a network that has pretty much moved nationwide. Like we have participants who come in from Canada, Ohio. I mean, it's definitely not a Florida-based echo anymore. We do have a couple upcoming sessions. We have one tomorrow on a community paramedicine program overview with the co-author of the MIH guidebook. And then we also have a roundtable discussion coming up in December. And we actually, one of the guests here today who's attending, Camilla Kajak from the Community Resource Paramedicine Program in Gainesville Fire Rescue, she will be speaking as part of one of the panelists and just going over different topics. We also will be launching some new topics coming in 2022. We're gonna touch more on health access models that reduce health disparities, community outreach strategies for vaccine distribution, mental and behavioral health issues related to COVID, and many, many more topics. Another echo that FRHA offers is health literacy, and it is with a collaboration of the Rural Health Partnership. We'll be offering a 11-part series on health literacy covering topics as LGBTQ and literacy, adding health literacy to community health assessment. So this will be actually our 2nd series of health literacy. We had one earlier this year. We are also partnered with UF Pediatric Pulmonary. And we are having another 9-part series on asthma and lung transplants. So we're very excited about these echoes that we offer and be able to help everyone enhance their training in rural areas of Florida. And again, I know they mentioned earlier that, you know, tomorrow is National Rural Health Day. So as part of FRHA, we are having a celebration, and we have 2 type of panels. We have an advocacy update that will be happening tomorrow from Scott Darris, and he will be doing the update of the advocacy in Florida. And we also will have a resiliency panel with some great speakers, as you see here. And then in the spring of 2022, we will be having a Rural Health Education Summit. We have not finalized that yet, but when we get that out, we'll get it to everyone. So that's sort of what FRHA is doing, trying to help develop and enhance everyone's skills and just be more aware of, you know, the different conditions and stuff that's going on and the different echoes, just being able to promote that and give people education opportunities. And that's all I have.
Great, thank you so much. I know a lot of folks are happy to know about the FHRA activities and the really good, timely information that's being provided through the ECHO model. So it's just great to see that it's gone from Florida to national. We're now going to turn it over to Miss Kalyn Lewis. So Kalyn, if you're ready, the floor is yours.
Hey, thank you. Good afternoon, everyone. Today I'm going to speak about serving people living with HIV in rural Florida. And I'm the HIV Program Director at Well Florida Council in Gainesville. So I manage 2 programs at Well Florida to serve people living with HIV. And the first one is the Ryan White program. It's a federal program that provides core and medical support services to people living with HIV who are uninsured or underinsured. The program was established in 1990 and is the largest federal program serving people living with HIV in the United States. More than half of people living with HIV in the US receive their services through the Ryan White program, which means that over 500,000 people are dependent on the program for access to doctor's visits, medications, labs, copay assistance, dental, mental health services, and case management. And a requirement of the grant is that we must be the payer of last resort. So if the client has access to Medicaid, Medicare, health insurance, or any other type of benefit, we have to access that first, and then Ryan White can pick up what was not covered. The program is funded at the federal level by HRSA, and it's broken into 5 different parts, but the 2 biggest parts are Part A and Part B. So Part A is for eligible metropolitan areas, which are big cities. Those are funded directly by HRSA, and they get significantly more funding than we do. So in Florida, the EMAs are Jacksonville, Orlando, Fort Lauderdale, Miami, and Tampa, St. Pete. And then the Part B program is funded to states and territories. So in Florida, it goes to the Florida Department of Health, and then is distributed with the intent to cover all of the other areas that aren't picked up by EMAs. So that would be all of our smaller rural areas. So we are the Ryan White Part B lead agency for Area 313, which is a 15-county service area in North Central Florida. We cover all the way up to the Florida-Georgia border, down to Orlando, and it's over 10,000 square miles. To qualify for the Ryan White program, a person has to be HIV positive, living at less than 400% of the federal poverty level. We need proof that they live in Florida, but their immigration status is not important. And then they cannot be receiving the same services from another payer source. So this is just our local program. The map on the right shows the counties that we serve. So in the 2020 calendar year, we served over 1,600 clients and provided almost 20,000 units of service. And over 1,300 of the clients went to one of our 7 Ryan White funded clinics to get their healthcare. We also provide case management, transportation, copay assistance, and dental to a significant number of clients. And then if you look at the map, the teal dots are where our clinics are located. So you can see that there's not a clinic in every county or in every area. And so that will be an important part of the discussion when we talk about barriers. HIV disproportionately affects people living in the South, which is demonstrated by this slide by the CDC. So Southern states account for 51% of new HIV cases each year, but only 38% of the population actually lives here. 45% of people living with HIV are located in the South, and 50% of undiagnosed HIV infections are in the South. So 8 of the 10 states that have the highest number of new infections are located in the South, and 9 of the 10 metropolitan areas with the highest number of new infections are in the South. So we're severely impacted by HIV in the South. This is also from the CDC and shows specifically which populations are most impacted. So you can see that the majority of new infections in the South are among Black or African-American men who have sex with men. And then actually the lifetime risk of getting HIV for someone who identifies as Black MSM is 1 in 3. And that always stops me dead in my tracks when I hear that. So it's really a priority population for us. And then after Black MSM, new infections are highest in Black heterosexuals, Hispanic Latino MSM, and white MSM. And then on the right, you can see that 24% of new HIV diagnoses in the South occur in suburban or rural areas, which is more than any other part of the country. And then finally, the opioid crisis is a significant issue in rural areas, and injecting drugs puts people at risk for hepatitis C and HIV infections. So in 2019, President Trump proposed a 10-year plan for HIV called Ending the Epidemic. And so the goal was to reduce new infections by 90%, which would mean we'd see less than 3,000 new infections across the entire country each year. So to get to this goal, there are a lot of different factors. So we need to diagnose people. We need to get people treated as quickly as possible. We need to protect people using things like PrEP for people who are at high risk of infection. We need to be monitoring clusters and respond to outbreaks, and then make sure that our healthcare workforce is all on the same page. And we're going to have a really hard time getting to this goal unless we address the barriers to HIV prevention and treatment that we see in rural areas. So here come the barriers. The first one is a lack of services and funding. So as I mentioned, the rural areas get significantly less funding than urban areas to treat HIV. So whenever there's a new federal initiative announced, like Ending the Epidemic, all of the money went to big cities. So in Florida, it went to 7 areas, and they got it a couple of years ago, and we still haven't received any funding from that initiative. Rural areas also have small populations and a lack of general funding, so they don't have the clinics, the labs, the homeless shelters, the dentists, the mental health providers, and food banks that our clients need. And so this lack of services makes it really hard for people to stay engaged in their HIV care and adhere to their HIV treatment. We also have a lack of HIV treatment providers in rural areas. So there are not infectious disease doctors or people trained to treat HIV in all of our rural areas. Many providers are not comfortable, or they're not up to date on the medications and treatment guidelines. And some of them are not even comfortable providing culturally competent care to people living with HIV. So we actually have a contract with the US College of Medicine, and we send their infectious disease experts into 3 of our smaller clinics because we don't have any local experts in that area. A huge issue for us is transportation. So here's the map again of our service area. So the teal dots are the clinics, but we serve clients living in every orange colored county. So for example, a client who lives in Dixie County has to travel up to 1 hour each way to get to clinic in Gainesville. And that's really hard because, like Dr. Flowers mentioned, rural areas don't usually have public transportation. So clients need their own car, or they need someone who can drive them so they can get to their appointments, get their labs drawn, get their medication. And when I first started working in the Ryan White program, I case managed ladies who were HIV positive and pregnant. So they can absolutely have a healthy pregnancy and deliver a baby who's HIV negative, but they have to be on medication and carefully monitored. So that pregnancy is considered high risk. Well, the only high-risk OBs in our area who will see these ladies work at Shands in Gainesville. And Shands is the only hospital that will deliver the babies. So I had a client who lived in Hamilton County in Jasper, which is like the Florida-Georgia border. So she had to travel an hour and 15 minutes each way to get to clinic at Shands. And then as she got towards the end of her pregnancy, she was supposed to be there once a week. So that's a huge burden to ask someone who has no resources, no childcare, no car of their own. And so as you can imagine, she missed a lot of appointments towards the end of the pregnancy. And I also had another lady who lived in Suwannee County, and she had Medicaid Transport. So as you remember, we're the payer of last resort. So we had to utilize that resource that she had access to. Well, they only make one trip a day from Suwannee County into Gainesville. So she had to get picked up around 5 o'clock in the morning, and she wouldn't get home till after 4 p.m. Regardless of what time her appointment was at Shands, she had to just sit in the lobby until the van was going to make its scheduled return home. So that was really hard for her because she had kids in school and no one was able to pick them up. So transportation is probably our biggest issue. We also struggle with stigma. So it's a huge problem in the South that affects HIV prevention, testing, and treatment. So clients experience stigma about their HIV status, about their sexual orientation, their gender identity, and behaviors such as injecting drugs. We struggle with privacy and lack of anonymity. Because of the stigma of HIV, many of our clients are terrified for anyone to find out their status. So they will drive past the closest clinic and travel out of county for fear of running into someone that they know at the clinic. So we actually have clients who get care in Jacksonville or Orlando because they know someone who works at the clinic. People also think if they go to the health department, that means they have HIV. So we have clients who will only come in through the back door, or clients who ask us to dispose of all of the packaging of their medication, and then they'll just tuck the bottle into their jacket before they leave. And it also makes it really hard for us to keep clients retained in care because they don't want us to leave them voicemails, they don't want us to do home visits, and they don't want us to send mail for fear of disclosing their status. There's also a lack of awareness. So historically, spoiler alert, a lack of awareness. So historically, the HIV epidemic has been in urban areas. So people tend to underestimate that HIV is a concern in rural areas. And so people aren't as aware of things like testing, prevention options like PrEP, and the importance of getting on HIV medication quickly after diagnosis. Next one is poverty and unemployment. So that affects people's ability to access services, to take care of their health, and to maintain stable housing. And we've seen in HIV care that housing is healthcare. The people who are not stably housed actually have the worst viral load suppression. So we tend to focus on that. There's a lack of health insurance in the South. So many states in the South, including Florida, did not choose to expand Medicaid. So there are large sections of the population without access to health insurance. So without the Ryan White program, the majority of our clients would not have a way to access life-saving healthcare or medications. There's a lack of smartphones and stable internet. So there's been a real push towards telehealth, especially with COVID, but many of our rural areas don't have internet access fast enough to do telehealth, or our clients don't have the smartphone that they need to do a telehealth appointment. People also don't feel comfortable talking about HIV or mental health in their home if other family members are around. So we were excited to offer telehealth, and then it wasn't really utilized. Another issue for us is HIV criminalization laws. So Florida is one of 26 states that have criminal laws that only apply to people living with HIV. So in Florida, having consensual sex, donating blood or organs, or engaging in sex work without disclosing your HIV status is a third-degree felony. So we've had clients who didn't want to get tested because if they didn't know their status, then they couldn't spend 5 years in prison for not disclosing it. And then finally, there's a lag in new technology, programs, and efforts. So Florida lags behind other parts of the country in quite a few issues related to HIV. So the criminalization law, for example, is outdated because it doesn't take into account if the person used protection or was undetectable, which we know means they cannot transmit the virus. We're also slow to initiate rapid access to treatment for people who are newly diagnosed, and we still struggle to get PrEP into the hands of people who could most benefit. Florida also just recently passed syringe exchange, but with significant restrictions. So only a few counties have gotten a program up and running, while other parts of the country like New York and San Francisco have had syringe exchange for 30 years. So to not leave you thinking it's all doom and gloom, I want to highlight a few ways that our program and other programs are trying to address these barriers. So with transportation, some areas offer van service. So Big Bend Cares is the lead agency for the Tallahassee area. They have vans that will travel up to 2 hours one way to pick up a client and bring them to clinic or bring them to get their labs. The van says Care Spot on it, so there's no indication that it's for an HIV visit. So that's a really great service offered. We are the only part of the state that offers gas cards to clients. So we will give them $10 to Marathon, BP, or Shell to help get to appointments. But this requires them to have a car or know someone who has a car and can drive them. And we're working towards being able to use Uber or Lyft as an option. I don't know if you've ever been in a rural area and tried to find an Uber. They're not too common, but hopefully that will help some of our clients. The state is also purchasing health insurance for clients through the Ryan White program. So ADAP is the Age Drug Assistance Program, and it provides antiretrovirals and other medication to clients. And they found that it's more cost effective to purchase health insurance through the marketplace for clients than it is to just purchase the drugs. So this is a great opportunity for clients to have health insurance, which means they have coverage if they need to go to the emergency room or if they need to see a specialist and take care of some other parts of their health besides just getting medication. And then we are launching a mobile app for clients. So this is called PL Cares. It was created at the University of Virginia specifically for Ryan White clinics. And it's an app that allows people to confidentially communicate with their care team. So it'll appear like a text, but it's HIPAA compliant, it's password secure. They can connect with other people living with HIV on an anonymous message board. So similar to Reddit, a lot of our rural areas, there aren't support groups or other things. So people really feel isolated. So we're hoping this is a way to connect with someone else who's in their same shoes, and they can talk about disclosing their status, they can talk about medications, or they can talk about football and the weather, just some way to not feel so alone. And then the app sends you daily check-ins, so daily medication reminders and check-ins about your mood. And if clients answer those more than half of the month, we are going to move towards paying for the client's phone that month or providing a phone. So that'll be a great opportunity to ensure that clients have access to a smartphone and we have a way to get in touch with them to keep them engaged in care. And then finally, we have a contract to be the syringe exchange operator for Alachua County. So we're excited to get that up and running. So here's my contact information and I will pass it on.
Thank you so much, Kalyn. That was excellent, eye-opening information. Really drives home the intersection of risk factors and why it's so important that we keep the focus on rural health access. So thank you. Turning it right over to Dr. Howard.
Hi, everybody, and thank you, Dr. Flynn. I will zoom through this to leave time for questions, which terrible pun was intended there. So today I want to talk briefly about a research project that I direct, which is funded through the VA Research Service and seeks to improve access to mental and behavioral health care for rural veterans, which, as you likely know, is a group that's disproportionately impacted by mental health issues. In general, veterans are more likely to experience such issues, and those in rural areas may find it really difficult to obtain services to meet their needs, in particular because a lot of these individuals often live in mental health professional shortage areas. Very quickly, this is a map which shows rural prevalence across the United States. All of the cream and brown areas represent rural or highly rural areas. And I know it's a little hard to see, but I've got a red rectangle here around North Florida, and you can see that it's almost entirely cream or brown color. So you know that there's a lot of rural in this area, as I think most of us do know. So now the program I want to tell you about is a VA community care partnership, which began in 2016, a few years before I came to FSU, and we've since continued it and added partners here in the Florida Panhandle. More recently, we actually were able to do this pre-COVID and get things up and running, and are still able to continue it thanks to our great partner at Weems Memorial Hospital in Apalachicola. But at this point, we've been doing this for over 5 years, and we're partnered with VA, the Iowa Primary Care Association. Our first FQHC partner is a rural serving federally qualified health center in Southeast Iowa. And then, of course, FSU, the Center for Rural Health Research and Policy. And then I mentioned Weems Memorial Hospital in Apalachicola. And here's a picture we're adding Weems. And then I should also make note that we've also been able to expand this in areas of Iowa as well with my colleagues who are at the VA in Iowa City and the University of Iowa. And so these two federally qualified health centers are in Dubuque and Cedar Rapids, Iowa. I think in total right now, if I'm counting correctly, we have this in 8 total clinics across 4 healthcare organizations. The main focus of the program is to increase mental and behavioral healthcare access for veterans who present in community-based or non-VA clinics. I mentioned we initially partnered with one FQHC in what is West Burlington, Iowa. They serve about 17,000 unique patients, but it also is not near a VA point of care. Everyone who gets care at this particular FQHC is at least 40 miles from the nearest VA clinic. And so, and this is despite the fact that we know there's a high concentration of veterans in this area. I think most importantly for this project, they're very limited in terms of what they can offer in terms of mental health providers. So they have a piece of a psychiatrist, a part-time psychologist. They have a few other options, but they're very limited across 17,000 patients, and wait times can get quite lengthy, as you can imagine. So why does such a partnership make sense? Well, VA is increasingly partnering with community providers to increase access to care for veterans at distance, which is actually legislated through what's called VA's Mission Act of 2018, if you've heard of that. So these partnerships are really visible right now and are a key focus of care delivery in VA. As we generally know, veterans receive care from non-VA providers. This isn't a new thing at all. But we're not typically very good at finding these veterans unless we know them to have another large payer like Medicare, or they originate in the VA system. And that's actually how this is typically studied. You find individuals who are presenting for care in VA, therefore you know they're veterans, and then you see where else they get care. But what about those who are not known to VA who present for community-based care? What can we do for them? And that's sort of the impetus for this. It's really hard to find these individuals. And at best, you may be able to loosely estimate who might be using community clinics based on census data for a particular area, for example, which in some sense is how we actually chose this initial community-based partner. It's also really hard to coordinate care between VA and community-based organizations. And that's not anything specific to VA. It just is really difficult to coordinate care. So, but for low resource clinics who may also be in these health professional shortage areas, like I mentioned, they could benefit from some of VA's resources to provide mental health care back to these individuals where they are residing. Very briefly, I'll go over the specific aims. We want to identify veterans who are seeking care, assist them with exploring eligibility and applying for benefits if they so choose, screen them for mental and behavioral health conditions, depression, anxiety, substance use, PTSD, and then ensure individuals that screen positive have access to care, whether in that community clinic or at VA. Part of this is determined by choice. Some of it's determined by eligibility. Some of it may be determined by, as I have a note here about using telehealth, if a veteran is interested in using telehealth and we have that option for that individual. And for most, given VA's resources, we've actually been able to do that. Not all choose that, but if they want to, they can. I think, and maybe I should, well, I won't back up, but I think one of the main reasons that it's appealing from the community partners is for a clinic that has limited resources but serves a lot of individuals. If you can sort of offload or transfer some of that care to another source, what it does is free up care opportunities for other people in that clinic, whether it's a veteran who's not eligible for VA, a veteran who wants to remain in place and get care there, or it could be someone who's a non-veteran who is waiting to get a mental or behavioral health appointment and they can't. Well, what it does is bump them up in line, if you will, and it reduces their wait time. Next couple slides, I want to briefly talk about, how we went about identifying them. Essentially, what we did was change the screening question that was used and get it embedded in the electronic medical record as a hard stop. Usually, if someone asks or a clinic asks about veteran status at all, it's simply, are you a veteran? And I think that leaves a lot up to interpretation. And we know from good data that show a lot of individuals either don't want to identify, or maybe they just simply don't believe themselves. So you can ask them and they'll say no, even though they may be. So what we did was change this item to what you see here on the right, which aligns with what VA recommends in terms of starting a conversation about veteran status. This table here is actually only data from this one clinic that we published in a paper about a year ago. And it shows that in 2015, before any of us had ever talked, they thought they were serving about 56 veterans on 17,000. We started having conversations about this in 2016. That number rose in part because there was, I think, an ad hoc emphasis on intake and doing a bit better job about this. When 2017 got here and we were able to make this change in terms of the item that we asked and then getting it embedded into the clinic EMR, it turns out they actually serve more like 500 or more. So instead of it being about 1 in 200 patients as they thought, it's more like 1 in 20. Here's a quick slide that actually just shows of that one calendar year I just showed you where they identified 555. We got about 60% of them to agree to the behavioral health screening. 20% of those almost agreed to accept behavioral health treatment. We have a care coordination element to this that I won't get into, but what this has actually done is we had a nurse care coordinator who helped coordinate not just mental and behavioral health care if they were eligible for VA, but also get them into other services. We also newly enrolled some individuals in VA care, so they were able to access sources of care that they did not have before. So we were able to increase access in that way. A couple quick implications, so we can leave at least time for one question. Clinical workforce training development. One of the things that we've done here on the provider side is actually hold trainings that VA puts on where we're able to help community providers better understand military culture, reintegration, mental health issues, and suicide. And then there's this sort of community of practice opportunity that we've been able to have between Iowa and Florida. So we have a lot of people on a monthly call where we share stories about this and sort of work to improve care. I will not go over the rest for sake of time. And then I'll show you this very last bit here that one of the things that I think this project has done is hold up that veterans are getting care in the community outside of VA. A lot of people naturally think you're getting care at VA, but this has helped show that we need to be reaching out and accessing or getting these individuals access in the community. And in fact, one of the last thing I'll share with you about the item that we had changed, HRSA actually changed the way that they mandate all FQHCs collect veteran status based on this project. So in 2020, they changed their UDS manual to collect it this way. And so we're gonna look here in a couple of years and see what that looks like across the country as a function of that. But that was my very abbreviated talk, and sorry to rush through it there.
Thank you, Dr. Howe, and thank you to all our panelists for a wonderful talk. I have notes written everywhere. This has just been very eye-opening, and it's just really good to hear from the people that's on the ground doing this work. I know we are pressed for time. We might have time for like 1 or 2 questions. So I want to give the audience the opportunity. If you have any questions, you can put a reaction of your hand up, or you can put it in the chat. So I'll give it a few minutes to see, well, maybe 30 seconds to see if anyone has any questions for our wonderful panelists. Okay, well, I do have one question, and maybe this goes to all the panelists, and it might be a loaded question, so I don't know if we'll have time to actually get through it, but just hearing about the conversation, the barriers and limitations for rural health services, I think about Dr. Flowers' first slide when she talked about thinking about it in a systems level. So I was just wondering if if anybody can share any efforts that you know that's being made to sort of bridge the gap for the lack of access in these areas with larger systems, as Dr. Hiron talked about, the VA working with local FQHCs. I know it's a push for patient-centered medical homes and that focus on mental health and behavioral health services. So I don't know if any of the panelists would like to share. I know we're at 1 o'clock now, but it would be great just to hear from one person if possible. Okay.
I think that's a great question. And I almost feel like we need a second session focused on rural health because so many issues were raised that we don't have time to really talk about. And I liked some of the solutions that we heard from Kalyn and from Dr. Flowers. And, you know, I can feel another one focused on rural health coming up. So we will conclude. Thank you so much, everybody, for your participation. Please look for our next announcement for our next quarterly BSSM community rounds. And thank you so much to the presenters. That was just outstanding. I have a ton of notes too. So we're seeing a lot of thank yous in the chat. Wonderful. Have a wonderful day, everybody.
Absolutely. Thank you.